Good afternoon, everybody, and welcome to this special event. This is the IOE Professorial Lectures. Welcome both online and in person. We have live streaming right now. This is an inaugural lecture by Jeff Bezemer entitled Teamwork in Healthcare, a close-up view of the front line. I'm Professor Li Wei. I'm the Dean and Director of IOE, UCL's Faculty of Education and Society. I'm really pleased to be able to introduce the speakers today and to chair the event. So to introduce the lecture, Jeff Bezemer is Professor of Communication at the IOE, as well as serving as head of our Department of Culture, Communication, and Media, and Vice Dean for our health-related work. He studied intercultural communication, obtained his MA in 1999, and educational linguistics, PhD 2003, from Tilburg University, the Netherlands, before joining the IOE in 2004. Aside from 2 years based in the Imperial College London from 2009 to 2011, IOE has been his academic base. With the late Günter Kress, Carey Jewitt, and others, Jeff has played a pivotal role in developing IOE's work in multimodalities and multimodal communication. He was promoted to professor in 2018. Jeff has also expanded our work in relating to health settings, which spans supporting medical practitioners as educators, as well as work that touches on healthcare and clinical practice. As we will hear more from Jeff, Jeff's research focuses on the semiotics of healthcare, how meaning is created and communicated in these settings, and includes studies with, among others, paramedics, and in operating theaters and intensive care units. These studies involve observing practice, interactions, team working in very close detail, all with the overarching aim of developing understanding and tools to support frontline staff and, by extension, the quality of healthcare. So, Jeff, I'm really looking forward, as we all are, to hearing your drawing together this work. Please, can I invite you to present your lecture? Thank you.
Thank you very much, Li Wei. I am delighted to talk to you tonight about teamwork in hospitals. Anyone who has ever been a patient in hospital or supported family or friends going into hospital will know that hospital care involves many different people with many different roles and responsibilities. That means that the quality and outcomes of hospital care are always contingent on successful collaboration and communication between health professionals. If we want to optimize care, we need to understand interprofessional teamwork. That is what I set out to do in the past 13 years. What I am particularly interested in is the everyday work of teams, especially when they are in the process of treating a patient in an operating theatre, for example, or in the intensive care unit. I am not trying to measure how well or badly a team or individual performs. I am trying to identify the means and mechanisms that health professionals have developed to make sense of and deal with the challenges they experience in their day-to-day work. You may be familiar with some of those challenges already. Frontline staff from the UK's National Health Service or other health services around the world may have told you about the effects of being understaffed, a regulation that demands too much time or that is impossible to comply with, an issue with the design of the room, complications that could have been prevented had crucial information been passed on to the right people at the right time, challenges related to a lack of effective support, assistance, and supervision, or a lack of adequate tools and resources. And then there's the emotional toll of working under these challenging circumstances. Of course, the pandemic put further unprecedented pressure on teams. To understand these challenges and the strategies that staff develop to mitigate them, I operate like an ethnographer. I spend time observing how teams work and under what conditions. I listen to their concerns and I read the documents that regulate and guide their practice. Here you can see me doing fieldwork in the operating theatres of a large teaching hospital in London back in 2009, when I had just started my first research project in a clinical setting. Whenever possible, I bring a video recorder into my research sites. Video does not record everything and needs to be very carefully managed. One needs to consider privacy and litigation and be clear about who can access the recordings and for what purposes. It is difficult to get approval for this type of research in the UK, not least because the forms we need to complete are not designed for this type of research. Indeed, there are barriers that have yet to be removed to ensure that healthcare can benefit from the social research that draws on direct observations of teamwork. So there is an important ethical dimension to video, and it cannot be used unless teams are comfortable being filmed. But it is a lot more reliable and more detailed than memories or notes taken on the spot. It can be replayed over and over again to reconstruct a chain of events, and it provides a relatively objective starting point for collective sense-making and reflection. When I talk about video, people often ask me about the so-called Hawthorne effect, the idea that people will behave differently if they know they're being watched. I can't dispute the fact that people manage the impressions they give of themselves when they are in the presence of others, as Irving Goffman puts it. But people working in teams are, by definition, always in the presence of others, and I have no reason to assume that they behave at their best simply because they know that a camera is running. For starters, that assumes that they, or we, already know and agree on what best practice actually is, and that they can choose to perform well or not so well whenever they want to. If only it was that easy. The clip that's playing now shows how I analyze video recordings in detail, using annotation software that's also commonly used by coaches of athletes, for example. I type out what each of the team members are saying and describe what they orient to and what they do. Through this close engagement with the video, what may at first seem like a messy chaos turns out to be organized around certain unspoken principles and practices, which can be made explicit and fed back to teams. Today I want to explore the question I put on this slide. How do teams accomplish practical tasks together? The practical tasks refer to the technical embodied dimension of the work of teams. We're looking at people that engage with the material world around them, looking at and touching things, manipulating things, using tools and technologies. The accomplished together highlights the social dimension of teamwork, the concerted effort that they make operating as an ensemble. The question leads me to discuss two conditions for successful teamwork: the organization of assistance and the calibration of understanding. You will already be familiar with some version of these practices, as they can be observed in all kinds of social domains. Passing salt at the breakfast table, for example, is an example of the organization of assistance. And a parent and child working to achieve shared understanding of a picture in front of them is an example of calibrating understanding. Here's how assistance plays out in the operating theatre. We're joining a bowel operation led by a consultant surgeon and 2 trainees. I use the term trainee here as it is common in the UK to do so, but it's not actually a very helpful term because it obfuscates their long experience. Whenever I refer to surgical trainees tonight, I am referring to very experienced surgeons who are in the final stage of a very long educational trajectory. You can see in this clip that a consultant is stitching. The trainee in the bottom right corner holds a big retractor. At the end of the clip, the trainee on the left cuts the tie that the surgeon is holding in his hands. There we go. What you may not have noticed straight away is that shortly before this moment, the trainee receives a pair of scissors from the scrub nurse. The video is looped so you can have another chance to see it before I move on to the next slide. And there are the scissors. And there's the cut again. So here we've got two assistants at work who act to resolve troubles or difficulties in the progressive realization of a practical course of action, as Cobin Kendrick and Paul Drew put it. We might simply call these courses of action projects. The trainee enables the surgeon to complete the stitching, and the scrub nurse enables the trainee to assist the surgeon by providing the tools he needs to cut the tie. The crucial point here is that the cutting of the tie is achieved without recourse to talk. Irving Goffman, the American anthropologist and sociologist I just mentioned in relation to how people respond to being watched, helps us explain this phenomenon. He observed that the line of our visual regard, the intensity of our involvement, and the shape of our initial actions allow others to glean our immediate intent and purpose. And here comes the key part, and all this whether or not we are engaged in talk with them at the same time. Indeed, we have seen that the surgical trainee watches the consultant closely and apparently gleans from the actions he is performing with his body where he is at, what he will do next, and what he will need from the trainee to pursue this project. This is where professional socialization comes in. Through experience, the trainee has come to see projects like this in terms of how she can facilitate them. The other project, the passing of the scissors, does involve talk, but it's minimal. Halfway through the clip, the surgical trainee turns to the scrub nurse and says, "Scissors, please." You didn't hear that, as I didn't play the audio, but it's the only bit of talk that was designed to mobilize assistance in this clip. The consultant and the other trainee are talking, but they are talking about the management of beds for post-operative care. That simple phrase, "Scissors, please," constitutes a request for assistance. The trainee actively mobilizes help here. She recruits someone to provide the tools he needs. But the phrase "scissors, please" does not provide all the information the nurse needs to be able to respond to the request. It doesn't specify, for example, which of the many different types of scissors that are laid out on the instrument trolley the trainee needs. And that's typical. To mobilize assistance, team members often use generic phrases that merely represent the tip of the iceberg, as it were. It assumes that the team members whose assistance is being enlisted can work out exactly what is needed by recognizing the project that gives rise to the request. Indeed, for the scrub nurse, the phrase "scissors, please" stands for an entire project. Once she has assessed what type of scissors are needed, she needs to identify the right scissors on the instrument trolley, pick it up, hand it over at the right time, at a moment when the trainee has made herself available to receive the scissors, and in a way that the trainee can easily and safely slide her fingers into the scissors. That ability to assess in this way is contingent on prior experience. I should add that surgeons often have idiosyncratic, specific preferences when it comes to the use of instruments, and they like those around them to learn those preferences quickly. So the same shorthand phrase can stand for something quite different depending on which surgeon is making the request. Before I continue with more examples, I'd like to enter into a small interlude about social semiotics, a discipline I draw on a lot in my work. Social semiotics is the study of sign making. Umberto Eco, an Italian semiotician and novelist, defines a sign as everything that, on the grounds of a social convention, can be taken as something standing for something else. In the terms of the French linguist Ferdinand de Saussure, the something is a signifier and the something else a signified. This slide represents the first two examples in these terms. To the surgical trainee, the stitching stands for something like surgeon needs to tie cut soon. To the scrub nurse, scissors please stands here for something like trainee needs stitch scissors. In the first case, it's a bodily action that functions as a signifier. In the second case, it's a vocalization. In both cases, the making of the sign, the act of attaching meaning to forms that were produced and recognized in the immediate environment, prompted the assistant to act. The point here is that by convention in the operating theatre, certain kinds of bodily work, bodily conduct, and spoken utterances can come to stand for specific needs, prompting assistants to provide specific kinds of assistance. Typically, there is a sense among teams that the more projects can be achieved without spoken utterances, the better. Scrub nurses take pride in knowing what the surgeons need before they're being asked about it. Surgeons sometimes complain if they need to ask. Sometimes nurses keep so-called preference cards of surgeons detailing what instruments they like to work with for which procedure. But the team's ability to organize assistance without resorting to speed depends in part on the amount of time they have worked together before. In the contemporary world, teams often haven't had a chance to work together for a very long time and may not yet have established conventions around assistance to draw. Staff mobility is high and rotas don't always accommodate stability. Some teams, such as resuscitation teams, operate more on an ad hoc basis, and staff may find themselves working with colleagues that they don't know well or not at all. In all these kinds of circumstances, talk will be required to make expectations explicit. Let's now move to the intensive care unit to explore some more examples of the mobilization of assistance. In these examples, a team has come together to deal with a patient experiencing a problem with the heart, and the patient's condition is rapidly deteriorating. In the illustration on this slide, you can see a doctor in the middle giving chest compressions. Compared to the elective surgery we just looked at, in this emergency situation, we can see a larger team at work, and they move about a lot more. They are also under a different kind of pressure, as there is an acute risk of the patient dying. In this context, assistance is typically mobilized with a question. For example, the doctors that lead these efforts often use questions such as the one on this slide. Can you get a laryngoscope? Are you happy to bag? Do you want to do chest compression? These questions specify a project and they address a particular team member. The you is then identified through gaze and perhaps a pointing finger. Anaesthetists also often use questions, but these questions often do not address anyone in particular. They are recruiting help from among the team. Can someone listen to the chest, please? Can I have a bougie, please? They may scan the room for candidate helpers and try to establish eye contact with whoever appears to be available. But they are not always in a position to look up. Unlike the team leader, they are also not in a good position to assess who is best placed to provide the assistance. I should note that grammatically these examples are questions or interrogatives, but they are closed up with a falling intonation. They are not actually open for negotiation. Can someone listen to the chest, please? Can you get a laryngoscope? Team members sometimes also use declaratives, specifying what they need, rather than the action that addresses their need. For example, an anaesthetist might say, I need a laryngoscope, again without addressing anyone in particular. Imperatives are also used. They include phrases like, continue chest compression, adrenaline, guys. Contrary to what you might expect, the teams I observe do not actually often use the imperative form. Assistance mobilized by these teams in either of these ways was usually successful. Team members processed the requests and provided the help that was requested. This is significant as it has been suggested that imperatives are more effective in these kinds of emergencies than questions like, can you get a laryngoscope, which may appear less forceful. When teams do encounter troubles with the mobilization of assistants, it is usually to do with the challenge of getting the attention of a candidate actor when in fact everyone is already very busy working on other projects. For example, this slide shows how a team was divided up into two different huddles when the team leader makes an important announcement that has an immediate effect and an immediate bearing on what the nurses are doing on the left-hand side of this slide. Yet as the nurses are engrossed in their own project, they have difficulty processing the announcement. When they turn around to seek confirmation of their understanding, the team leader has already turned her eye back on the anaesthetist next to her. It is the junior doctor in the middle who then steps in to repeat the team leader's message. I now turn to that other condition for effective teamwork, the calibration of understanding. Here I take inspiration from the work of Charles Goodwin, an American linguistic anthropologist. He asks, how are embodied knowledge, skill, and professional vision calibrated through systematic practice to create the competent actors that sustain a community's distinctive ways of knowing, experiencing, and acting? Goodwin invites us to look closely at teams and identify how they develop and sustain a shared way of understanding and doing things. So we are going to return to the operating theatre and explore how surgical teams arrive at and acknowledge shared understandings of the patient's body, and how these shared understandings become the basis for decision-making during an operation. What you will see is that calibration serves at least two different functions: a pedagogic function to facilitate learning among the team, and a clinical safety function to check understandings before acting on it. But before we do so, I should say a few words about laparoscopic surgery, which is where I got the examples from. In traditional open surgery, surgeons look down, head to head, onto the patient. They are somewhat in competition to obtain a clear view of their operative field. In laparoscopic surgery, surgeons stare at screens that project the view of a camera that one of them controls. So they have the exact same view, and there's no way to hide anything from any of the other team members. It renders their work entirely public to whoever happens to be in the room. This laparoscopic approach alters the surgeon's practices of seeing. Everything they see is mediated by the camera and screen. They cannot make sense of the patient body through direct touch. They can only get a feel of the structures they operate on through the long, thin instruments that enter the patient's body through small incisions. I'll now present 3 examples from laparoscopic gallbladder operations, which is a very common procedure. In the example on this slide, there's a consultant surgeon on the right who is operating with a surgical trainee standing on the left. The trainee controls the camera and holds a retractor to lift the liver up. He is effectively assisting the consultant. They are looking at the gallbladder, and the consultant has stripped away some fatty tissue to expose underlying structures. Then the consultant initiates a calibration exercise. That's the duct, isn't it? It's in continuity, there's nothing medially. I don't see what else it can be, is it? Cystic duct, isn't it? Go in. This example illustrates a number of things about the calibration of understanding. Firstly, there's the issue of indexicality. The consultant uses a distal demonstrative pronoun, that, to refer to the structure he is pointing at with his instrument. Surgeons make these pointing gestures all the time. They draw attention to specific areas of interest, which are then subjected to calibration. But note that not everyone in the room is in a position to point. In the present example, only the consultant can. The trainee needs to hold the camera and he can't let go of the liver retractor. If the trainee wants to comment on what he sees, he can at best try to identify areas of interest by describing them. The consultant might then reply by pointing at the place he thinks the trainee is referring to, saying something like, "You mean here?" These kinds of exchanges are very common and essential groundwork. Before the team can begin to talk about any understanding, they need to establish what it is they're talking about. Perhaps unsurprisingly, surgeons use many technical terms when they calibrate their understanding. These terms, such as cystic duct, stand for categories through which surgeons see the human body. They already share understanding of what these categories stand for in abstracto. They have all seen diagrams, 3D models, and many real examples of these categories before. But each real instance of these categories is different, and every time they encounter another instance of it, they need to establish whether it really is an instance of this or that category. And that is what is happening here. The surgeon points at the structure in the body in front of them, prompting a cognitive mapping exercise. People in the room are invited to hold this real concrete structure next to their mental image of the cystic duct, an image they developed through prior calibrations with other surgeons and studying textbooks. Every surgeon brings their own mental catalogue to these operations, and through each new operation, they expand and refine it. Now, here's what makes these calibration exercises in surgery so intriguing. The ease with which team members recognize these categories does not just depend on the prior experience of the surgeons. Some categories are relatively easy to notice. Anyone who's had some basic lessons in anatomy will recognize the liver in a body and the gallbladder underneath it when they push the liver up. Other structures are notoriously difficult to identify, such as the cystic duct. It is usually buried underneath tissue that those surgeons need to carefully peel off to render it visible. Before any of that tissue has been taken away, it hardly looks like a distinct structure at all. Once it does become visible, it can still be mistaken for something else, namely the common bile duct. Getting the identification of these structures right matters, as it is the cystic duct that needs to be divided before the gallbladder can be removed, and not the common bile duct. Getting it wrong can result in serious complications, which is why in these operations the calibration is generally focused on precisely that category. In the first line, and again in the penultimate line, the consultant explicates his current understanding of the structure he's pointing at. He thinks it is the cystic duct. In the lines in between, he presents the evidence for this interpretation in terms of the position of the structures relative to its surrounding structures. So he recognizes and explicates a pattern of what we might call corporeal forms, which to him and other surgeons have come to stand for cystic duct. We might say that the consultant is making meaning, sharing his thoughts and encouraging others in the team to do the same, so that they can effectively compare notes. But the consultant also expresses some reservation. A thread of doubt remains, as his "isn't it" suggests. And that too is very common. Surgeons develop hypotheses about what they see, initially marking high levels of uncertainty. That might be the cystic duct, and eventually expressing high levels of certainty. That's definitely the artery. To gain more certainty, in this example, the consultant asks the trainee to change the camera position. This reminds us of the fact that all evidence for a hypothesis about what they see is not always visible from one camera position. The team needs to constantly work together to render relevant areas visible. Here's a quote from an American surgeon talking about his experience of participating in the calibration of understanding of the cystic duct during gallbladder removal operations. Let me read it out for you. Then, to be absolutely sure we were looking at the gallbladder duct and not the main bile duct, I stripped away some more of the surrounding tissue. The attending and I stopped at this point, as we always do, and discussed the anatomy. The attending is the US equivalent of the consultant in the UK. The neck of the gallbladder led straight into the tube we were eyeing, so it had to be the right duct. We had exposed a good length of it without a sign of the main bile duct. Everything looked perfect, we agreed. Go for it, the attending said. Like me, Gawande highlights the social cognitive dimension of calibration. They're making sense of the anatomy together. They are thinking together. He suggests the same anatomical forms to look out for to establish whether one is looking at the cystic duct. He also highlights the fact that the division of this structure involves the explicit approval of the consultant. This safety procedure still does not guarantee that teams get the interpretation of the structure right, as Gawande goes on to tell in his book titled Complications, A Surgeon's Notes on an Imperfect Science. Surgical work is also semiotic work. The human body does not speak for itself. In my next example, it is the trainee who is operating under the supervision of a consultant, just as in Gawande's example. At some point in this operation, the consultant says, "I think you're probably fine there now, Michael. I'd just take it all." What he means is that he is satisfied that the structures the trainee has exposed are indeed the cystic duct and the cystic artery, and that it is therefore safe to now divide them. Note that it is the trainee who is holding the metaphorical scalpel here, but it is the consultant who makes the call. In the 12 gallbladder removal operations that I have observed in one teaching hospital in London, this was the default approach. The consultant initiates episodes of joint sense-making. The consultant does afford the trainee a degree of autonomy by framing his understanding of the anatomy as his personal view. He says, "I think," and he makes a proposal, "I would," rather than giving a strong directive. But the trainee appears to simply take it as a directive. He responds by asking, "Clip 'em?" So he translates the consultant's proposal. "Take it all" becomes "clip 'em," and he asks the consultant to confirm that reading of his proposal, which he does. So agreement has been reached and explicitly stated. In what follows, the consultant justifies his proposal by drawing attention to the evidence in the anatomy. He says, "Because you can see if you push up on the gallbladder with your hook, just push up on the gallbladder, go through there, and you can see you've got a nice big window there." So he talks about a nice big window, which describes the larger structure that includes the cystic duct and also the cystic artery. It is vernacular for callous triangle and stands for another key category in the surgical discourse associated with this procedure. The consultant is following the operation from the corner of the room, so he can't actually manipulate the gallbladder himself. Hence the instructions like push up on the gallbladder. They remind us of the fact that as well as adjusting camera position, the object of interest itself needs to be flipped around and manipulated in other ways to render specific features of it visible. Features that are taken as evidence of hypotheses about what it is. My final example illustrates the calibration of understanding between two trainees without a consultant co-present. Here it is the operating trainee who makes the call. It usually takes at least 15 minutes or so of careful dissection to obtain that nice big window that the consultant in the previous example talked about. That is achieved here with a single maneuver. Not so much because this trainee is better at the job than the previous one, but because the anatomy in this patient happens to manifest itself so clearly. As soon as that window appears, the trainee says, "There you go," noting this achievement, which seems to come as a bit of a surprise himself. The other trainee responds with a brief, "Nice." Whatever that exactly means, it expresses affirmation. They're in agreement about something. The trainee then starts making gentle sweeping movements with the tip of his instrument along the sides of the window to evidence that it is entirely free and that there's nothing else behind. And while he makes that gesture, he says, "Agreed?" By doing so, he asks his fellow trainee to commit to the shared understanding that they're eyeing the right structures and that it's safe to divide them now. The other trainee then simply expresses his agreement by saying, "Yes." So very few words are spoken in this example, and hardly anything is made explicit through speech. But the words that are spoken do something really important. They confirm a commitment to a shared understanding. Inasmuch as we can say that this understanding is made explicit, we'd have to give the credits of that achievement to the gesture that the operating surgeon uses to trace the shape of the structures. That concludes my examples. Now let me try to summarize what we've seen. The bullet points on this slide describe 3 fundamental features of teamwork that the examples I presented have illustrated. The first feature revolves around regularity. Professional communities and local teams develop social conventions, routine ways of doing things and seeing things together. We have seen how this enables team members to anticipate what others are likely to do next and to communicate a lot with a few words. We have also seen how surgeons across the Atlantic seem to be following very similar calibration procedures to minimize the risk of misidentifying crucial anatomical structures. The second feature highlights that teams always operate under varying levels of uncertainty and unpredictability. Exactly how a procedure unfolds is contingent on many different variables: the patient body, the composition and prior experience of the team, their history of collaboration, the availability and quality of tools and technologies, and so on. At some general level, teams go through similar steps and follow similar principles. Still, every procedure is made up of a unique sequence of actions. It is always emergent. And so no clinical procedure is ever exactly the same. Their successful accomplishment always demands creativity and improvisation, finding ways to make things work under the unique specific circumstances of the situation. Which means that with every new engagement, learning happens, not just among the trainee, but among even the most experienced members of the team. And this is where I believe the value of qualitative research of the kind I discussed tonight lies. Any intervention in the delivery of healthcare, every effort to improve healthcare, ought to recognize each of these 3 features. Without attention to either of them, the intervention is unlikely to succeed. Healthcare should not be assessed on the basis of outcomes alone, and the processes that produce the outcomes are too complex to reduce to a handful of global rating skills. The devil is in the detail, and that is where the video comes in. And so I'd like to make a plea for the creation of a NHS video observatory to systematically gather, curate and share video evidence of instances of actual healthcare practice, and to enable all relevant research disciplines to analyze the footage and work with the health professions to explore how their day-to-day work can be alleviated. In the US and other parts of the world, video and other data is already being systematically collected from the operating room, for example, for research purposes. In some health services in the UK, video is also collected, but it's not available for research. For example, paramedics have been given body-worn cameras in the hope that being video recorded will stop members of the public from being aggressive or even violent towards them, which unfortunately happens regularly. At the moment, this video footage of actual incidents is being used to help prosecute the perpetrator, but not to gain better insight in, for example, conflict management. When health professionals talk about teamwork, they often talk about coordination, monitoring, situation awareness, and leadership. What I hope to have shown is that this common language of teamwork is compatible with, and can indeed be enriched with, a different language, a language derived from social sciences with a long tradition of studying and theorizing meaning-making and social interaction. I believe that healthcare can advance discussions about teamwork if it was to adopt notions like the organization of assistance, the calibration of understanding, the making of signs, indexicality, hedging, and so on. They all draw attention to distinct aspects of teamwork. They constitute distinct examples of real-world challenges and practical bespoke solutions designed to address them, all of which are worthy of close scrutiny and reflection. Which is why I try to inject these terms and these categories into the reflexive discourse of the healthcare community. With Günter Kress, I believe that there is merit in adopting this social semiotic perspective. He argued that we need a theory that deals with meaning in all its appearances, in all social occasions, and in all cultural sites. This resonates with me as my first degree was actually in applied linguistics. This discipline has a long tradition of analyzing healthcare, but it has focused on what health professionals do with language, especially in conversations with patients. What the examples I discuss tonight have shown is that it is quite impossible to reflect on language use in healthcare in isolation. When health professionals engage in practical teamwork, in as much as they talk at all, it is entirely entwined with their bodily conduct, the shape that their objects that they're working on take on, the tools they use, and so on. Günter's preferred way of talking about this interconnection between language, body, and material environment was multimodality, and we have written about this idea together, as have many of my colleagues. He argued that people use different modes of communication, such as speech and gesture, together in conjunction. He would point out that each mode contributes differently to meaning making. The pointing gesture is one thing, spoken utterance does something else, something quite complementary. We have seen examples of this tonight. Remember the surgeons pointing at structures while talking about them. But multimodality does not tell the whole story of meaning making in healthcare. Health professionals invest material forms of all kinds with meaning. Not only do they read the pointing gesture, which was evidently made for communicative purposes, they also read the act of stitching as a sign of what comes next. And they make sense of and communicate about shapes and forms inside the patient body. It is my ambition to advance social semiotics by accounting for these somewhat different semiotic phenomena, which are not easily described in terms of multimodality, which makes the relation between social semiotics and healthcare one of mutual benefit. Each can be advanced by bringing them together. And that has brought me to the man I dedicate this lecture to, Günter Kress. Günter took me under his wing when I joined the Institute of Education nearly 20 years ago. I was then a young postdoc coming from the Netherlands on a scholarship from the Dutch Research Council, the NWO. Günter was my mentor and became a close friend. He has profoundly shaped my own professional vision by being the extraordinary observer of human meaning-making and social interaction that he was. He was great at asking the right questions, bringing to the fore social relations that were somehow obscured or taken for granted, questions that we not have thought of ourselves. And that asking the right question is, I believe, what makes a great academic. Claude Lévi-Strauss, a French scholar, noted that the scientist is not the one who provides the right answers, it's the one who asks the right questions. I am immensely grateful for the questions that Günter has left behind, which will occupy me for some time to come. And I am proud to be wearing his professorial gown today in his honor. Thank you, Jill, for making that possible. I should also acknowledge the funders that have supported the research that I have talked about tonight. They include the London Deanery, the Economic and Social Research Council, and the Wellcome Trust. And of course, I am also grateful to the teams I have observed over the years and who featured in tonight's talk. Then there are all those other people that have played an important role in my journey that led to this day. Firstly, I am indebted to my other mentors, and I'm so pleased that two of them will be speaking in a moment. They have all been incredible sources of inspiration, encouragement, and generous support. Ben Rampton showed me how to build convincing arguments from observations of seemingly small details in people's talk. The late Jan Blommaert taught me how to look beyond those direct observations and consider the invisible and the inaudible forces at play. Carey Jewitt showed me how to advance and innovate a field of knowledge and how to manage a research project effectively. Roger Kneebone introduced me to the world of healthcare and taught me to explore parallels between different professional domains and turn something that is quite complex in terms of research findings into a story that makes sense to a whole audience. And I hope to have achieved some of that tonight. Secondly, I'd like to thank all the many other colleagues I have exchanged ideas with in the past 2 decades. When I first joined the IOE in 2004, I was lucky to be part of a lively group in the Department of Culture, Communication and Media that had started to explore multimodality in education. And I have warm memories of our collective efforts to lay the foundations of this new field. Some years later, at Imperial College London, I joined an exciting multidisciplinary team of social scientists, clinicians, and technicians that looked at surgical education and surgical simulation. When I moved back to the Institute of Education, I joined the Knowledge Lab, which gave me a chance to engage in discussions about media and technology. Since the Institute of Education merged with UCL, I have benefited greatly from cross-faculty conversations about health. Throughout my time in London, I have enjoyed also great conversations with academics from different parts of King's College London, mostly around language, discourse and interaction. I was an active member of the UK Linguistic Ethnography Forum, and for many years I co-organised the Ethnography, Language and Communication Summer School. I was also lucky enough to be part of several European research networks through which I have greatly enhanced my understanding of learning and social interaction. And I learned a great deal from working with my doctoral students and postdocs. Thirdly, I want to thank my family, who created a safe environment for me to grow up in and gave me the freedom to discover the world. Lastly, I am immensely grateful to my dear husband Jamie for all his care and affection and his passionate advocacy of my work. I have spoken.
Thank you so much, Jeff, for that fascinating linguistic, ethnographic, and social semiotic dissection of interactions in the operating theatre. I think that the majority of people are not aware of what's happening in the operating theatre. I hope at least the patients are not aware of what's happening. So it is really fascinating to see and hear and watch some of the details and your analysis of that. It's a wonderful example of the kind of innovative and interdisciplinary work that is happening in the IOE and across UCL. I think we are in this wonderful environment for this kind of research. As is customary to our professional professorial lectures, we are now going to hear a brief response. But less customary and very special on this occasion, we're going to have 2 respondents, Professor Carey Jewitt and Professor Roger Kneebone. Carey is a social scientist with a fine art background. She is Professor of Learning and Technology at IOE and Fellow of the Academy of Social Sciences. Her research covers multimodal interaction, including most recently digital touch, and is highly innovative in terms of her methodological approach. As we noted earlier, with Gunter Kress and Jeff, Carey established IOE as a leading center for research on multimodal communication. She previously served as head of IOE's Department of Culture, Communication and Media, which Jeff is heading now, and directed 2 of our research centers, the Center for Multimodal Research between 2007 and 2012, and previously known as the London Knowledge Lab and now UCL Knowledge Lab between 2016 and 2018. Both are globally renowned and contribute hugely to the IOE brand. Carey is also founding editor of the journals Visual Communication and Multimodality and Society, and is chair of UCL's collaborative social science domain, which works to foster multi- and interdisciplinary research between UCL's faculties. Roger's background, by contrast, is in medicine, and he is currently Professor of Surgical Education and Engagement Science at Imperial College London. Having trained as a surgeon, he later moved into general practice. His involvement with surgical training led him to Imperial, where he has continued to pioneer highly interdisciplinary programs for medical education. His research has focused on the use of stimulation in medical training and, more recently, public engagement, as well as awards for his teaching and engagement. In 2019, Roger was elected Professor of Anatomy at the Royal Academy of Arts, the 14th to hold this post since William Hunter at the establishment of the Royal Academy in 1768. Carey and Roger, really grateful for you to be here. I think, Roger, first, over to you.
Thank you. Well, thank you for inviting me to respond to Jeff's inaugural lecture. When I first met Jeff in 2009, I'd been an academic at Imperial College London for nearly a decade. Before that, I'd trained as a general and trauma surgeon, and then I'd changed direction and spent almost 20 years as a GP, a general practitioner, in the southwest of England, where I became increasingly interested in teaching and learning. At Imperial, I established a master's program in education, in surgical education, introducing surgeons to ideas from the world of education. But I'd never heard of social semiotics or ethnomethodology. Günter Kress changed all that. In 2006, I began thinking about mapping the operating theatre as a site of learning and teaching. I'd spent years as a surgical insider, learning the craft of operating through a long apprenticeship. I'd worked within surgical teams as a trainee, and eventually I'd come to lead them myself. But all that time, I'd been focused on my own role. I hadn't thought about surgery as the complex educational ecosystem which Jeff has just described. A colleague at Imperial suggested that I get in touch with Günter Kress at the Institute of Education. I'd never heard of Günter, but I rang him up out of the blue. To my astonishment, he agreed to see me a couple of days later, and although he'd never worked in the medical field, we hit it off at once, and we began to collaborate. By 2009, we'd managed to find some funding. Günter said, "We need an ethnographer," and I know the very person, and of course that was Jeff. Jeff had never been in an operating theatre then, but he quickly found it fascinating and agreed to join us at Imperial as a researcher, and the rest is history. Jeff's combination of detailed observation and wide thinking proved a perfect recipe. To me, this was an eye-opener. As we've seen, Jeff set out to give names to what had gone unnoticed and to bring the hidden into view. He disclosed things that were there all the time, but which surgical insiders like me had either never seen or had stopped noticing. Jeff looked through his microscope, as we've heard, at tiny actions and gestures that go unrecognized, but often carry crucial meaning, and he pulled them together to tell a story. So as a surgeon, your focus is on your patient on the operating table and the role that you play in each procedure. Identifying nuances of communication isn't top of your list. Assisting in the operating theatre is a good example. We've heard a lot about assisting. But assisting when you're doing it is not glamorous work. As a trainee surgeon, I'd spent far more time than I wanted in long, difficult operations, open operations, hanging onto one end of a retractor whose other end I couldn't see, with my muscles screaming out to change position, but not being able to move. But to Jeff, analysing the role of the assistant was an opportunity to make new discoveries about how people communicate, as we've been hearing over the last hour or so. And again, he would take a tiny, often apparently insignificant moment in a video recording and immerse himself in it. He'd watch and re-watch until it revealed hidden layers of meaning. When he did that with assisting, he uncovered complexities that insiders seldom notice, and I most certainly hadn't. What he disclosed was what was going on under the surface, those subtle, complex forms of communication that participants themselves were usually unaware of and certainly had no words to describe. So as we've seen, Jeff soon expanded his scope to examine other areas of clinical practice, such as emergency care in the intensive care unit. And I think this has huge power in reframing how we think about clinical practice and education, and bringing those worlds of education and medicine closer together. Since that work in the operating theatre, of course, Jeff's career has gone from strength to strength, culminating in his chair here at UCL. During this lecture, we've had a fascinating insight into how his ideas have developed over the years and how he's opened new ways of thinking about worlds which insiders so often take for granted, how looking deeply changes what we see. It's fitting that Jeff finished his lecture with an image of Günter Kress, a man whom we both loved and who influenced us both profoundly. Günter gave an address after my own inaugural lecture at Imperial in 2012, and so it's a great privilege to be invited to do the same at Jeff's, 10 years later, almost to the day, and to celebrate all that Jeff has achieved and all that we both owe to Günter. So I can't wait to see what Jeff will do next. Thank you.
Hello. I'm going to switch track a little bit and talk about Jeff, the researcher and colleague that we know. So it's a real pleasure to be here, and it's a pleasure just to be a friend of Jeff and a colleague of Jeff. So Jeff, as we've heard, joined in 2004 as a postdoc funded by the Netherlands Scientific Organisation, and he came to work with the data from the multimodal production of school English, which is a project led by Günter, funded by the Economic and Social Science Research Council, and I was the researcher on that project. And he had a choice of coming to the IOE or going to Southampton University, and I am so pleased that you chose IOE, and I think you're very pleased that you chose IOE as well. So from the get-go, Jeff's calm, kind, intelligent, precise and rigorous disposition as a researcher, which I think we've all seen tonight evidence of, was apparent in his approach to the people and the experiences that the data captured. And I think it's that ethics of Jeff that's really valuable in the way that when he's looking at this data, he's seeing people and he's seeing interactions in a strongly social sense and not in a judgmental way, as you set out in your talk. And I remember me and Günter being really excited at you coming to join the IOE, and really excited at the ways that Jeff brought new life and understanding to the project data that, in the same way that Roger's talked about, we'd been looking at for some time, and you made it new again. So as Jeff's lecture this evening's evidence, he's got a great kind of multimodal feel for the world and for how people communicate and interact. And that's a great thing to have. So Jeff went on to collaborate with Günter on a number of multimodal projects, including what I think now is a really seminal project for many of us here and around internationally, which is the Gains and Losses project. And that project interrogated changes in textbook design over a 75-year period. And together they questioned the design and principles of composition of present and future roles and forms of writing and explored their implications for learning. And I think that work, you can see that work in a sense sitting behind what Jeff shared with us tonight. And very sadly for me, in 2009, Jeff briefly left the IOE for Imperial, although he continued to work with Günter together with Roger, as we've heard, and colleagues, and they began to work on expanding the reach of multimodality to the domain of health, communication, and education, which is such an important contribution. But luckily for me, and for the IOE, a few years later, Jeff returned as Deputy Director of MODE, which was a large ESRC project which enabled us and Günter to work together again. And Jeff's continued to develop his work on multimodal communication in the surgical operating theatre, as we've seen tonight, more broadly. And I asked Jeff's collaborator, Professor Rick Edemer, who specialises in team-based practice and learning in healthcare at King's College London, to just share a few words with us about Jeff as a scholar, because he can't be here tonight, he's in Australia. He said, "The words that spring to mind about Jeff and his work are that he has ventured more deeply than anyone else I know into the intimate details of medical relationships and surgical practices, which given their protected nature is an achievement in itself. And that must be due to his gentle, collaborative and probing and open-minded approach to academic scholarship." So Jeff remains a key to the IOE's leading reputation in multimodal research and a leading scholar in his field, as well as expanding out the IOE's work in health education. And over the past 5 years or so, Jeff's also taken on the challenge of leadership roles at the IOE, which I think is great for many of us in the room. And I asked our colleague, Professor Sue Rogers, interim director of the IOE prior to Li Wei's appointment, to share a few thoughts about Jeff as a leader, in part because every single time I speak to her, she sings your praises so much. So I wanted to give her a voice tonight. She said, "Jeff's a leader of enormous talent and ability, widely respected for his quiet leadership." There's a bit of a theme coming out here, isn't there? As acting director of UCL Knowledge Lab, head of the Department of Culture, Communication and Media, and me and Sue have both been heads of that department, so we always want it to be in good hands. And more recently, in his role as the Faculty of Vice Dean for Health. So over the years, it's been fantastic, Sue says, to watch Jeff grow into these roles. His calm and measured approach to solving problems, which I think we've all probably experienced at one point or another, always fair, preparing well, and weighing up the evidence carefully in his decision-making. She says, "I value hugely his sharp intellect, compassion, and insight into tricky situations." So, as I said, Jeff's my head of department, so I can only agree with everything that Sue said. But Jeff, thank you for your scholarship, for your leadership, for your company, especially in hard times, and for your friendship. And I'm just so pleased for all of us that you chose the IOE. So please join me, everyone that's here, in congratulating Jeff on his successful journey from postdoc to IOE Vice Dean Health. And really congratulations to all of the people here who've supported Jeff throughout, notably his wonderful husband, Jamie, and Jeff's family, who I'm really pleased are here today to celebrate this momentous occasion. But as well, our much missed and loved mentor, Professor Günter Kress. And as Günter would often say, "You done good."
Thank you, Roger. Thank you, Carey, for those remarks. And thank you again, Jeff, for that stimulating talk. Wonderful to hear your work, and congratulations on your achievement. I want to thank Emma, Francis, and the entire IOE Comms team for organizing today's event. That sadly is the end of our formal proceedings. We have lots of professorial and other lectures. Please keep an eye on the listing on our IOE website. We have to say goodbye to those who are listening to this lecture online. Thank you very much for being here. And for those who are here in person, please continue the conversation with Jeff and others over a drink. Thank you.